Hi guys, this is Dr. Santosh Patil and I welcome you all back on the Preplatonitis platform, and today we are connecting to discuss or learn about medium vessel vasculitis. Now when I say medium vessel vasculitis, the first thing that strikes your mind is polyarteritis nodosa, right? A disorder of adults. And the second thing that strikes your mind is Kawasaki disease. One more cause for medium vessel vasculitis, which is a disorder of pediatric age group, right? These two are classically described under the heading of vasculitic syndrome. So we will be learning about these two specifically today, right? But there is one more medium vessel vasculitis I want you to remember, mainly from the MCQ perspective, that is thromboangiitis obliterans, right? Not typically covered under the heading of vasculitic syndromes. It is usually dealt separately, and we will also be dealing with that separately. But remember, it is also a medium vessel vasculitis. So if there are MCQ which are basically asking you which of the following is not a medium vessel vasculitis, and they present this as one of the options, remember it is also a medium vessel vasculitis. Okay, now let us begin learning about polyarteritis nodosa. What is polyarteritis nodosa? It is a medium vessel vasculitis with striking predilection for certain organs. So what are the organs we are talking about? Those certain organs are basically the number one most commonly affected. Which one? Yes, kidneys, right? Kidneys are the most commonly affected organ. Then we have characteristic involvement of gut, and we also have striking predilection for involvement of peripheral nerves, right? So this summarizes the polyarteritis nodosa. Okay. Now, if we talk about its epidemiology, a little is known about it because this is a relatively rare disorder. So in terms of its pathology, pathogenesis and epidemiology, we don't understand too much, right? What we understand so far is that males are more affected than females, and a typical patient would be diagnosed in 5th or 6th decade of their life, right? That's all we know, and I think probably that's all we need to know for the exams. Now let me take you to the etiology of polyarteritis nodosa. So based on the etiology, polyarteritis nodosa cases can be divided into primary and secondary. We are all already familiar that hepatitis B is classically associated with polyarteritis nodosa, but even to some extent, maybe to a lesser extent, hepatitis C is also associated with polyarteritis nodosa, right? Other than that, there is a malignancy, hairy cell leukemia, which has been linked with the causation of polyarteritis nodosa. But the secondary causes are not restricted only to these three. Right? If you probably look at the literature, these three might account for more than 90% of the cases of secondary polyarteritis nodosa. But there have been studies which link various other malignancies with polyarteritis nodosa, and similarly various other infections. For example, recently I was going through a review which says Klebsiella infection is also classically associated with polyarteritis nodosa. But in terms of exam preparedness, I would say if you know hepatitis B, hepatitis C and hairy cell leukemia, I think that should suffice. Okay. Now coming to primary, obviously we know this is a disorder which is idiopathic. That is why we are calling it as primary, right? We don't know what is causing it, so we are calling it as primary. But there are some certain recent studies which link a mutation in a gene called SERC1, right? SERC1 or CERC1. These mutations have been implicated in causation of primary idiopathic polyarteritis nodosa, and this I would see as an important MCQ point for those who are preparing for INI-CET. Okay, so with the understanding of etiology, let us go on and understand the pathology and pathogenesis. I've already told you we know a little bit about its pathology and pathogenesis because the intricate cascade of events or the molecular chain of events that are responsible for triggering the vascular inflammation is not well understood, right? So what we know so far is this is a disorder which is affecting small and medium vessels, right? We know we are classifying it under medium vessel vasculitis because predominantly it is affecting medium vessels, but it can also affect small vessels, right? So that is something that we should know. And when we biopsy such vessels and look at the nature of inflammation, we would notice that if it is an early disease biopsy, right, in the early course of the illness, then the vessels are usually infiltrated by polymorphonuclear cells, or in other words, neutrophilic inflammation. But as the disease progresses, in the later part of the disease, we would notice that the inflammation is because of the mononuclear cells, right? Mononuclear cells in the later part of the disease. But beginning with the neutrophilic inflammation and later with the lymphocytic infiltration, what are we seeing? Finally, there is necrotizing inflammation, and this necrosis is typically fibrinoid, right? Fibrinoid necrosis. Okay. And furthermore, we should be aware that generally we don't see granulomas, which sets it apart from various other vascular conditions where the vasculitis is granulomatous, right? So there are no granulomas in case of polyarteritis nodosa. And the vessel involvement is usually segmental, mainly affecting the bifurcation of arteries, right? If there are two arteries and they are bifurcating, that is the most strikingly affected site. Okay. And the other thing we should note about its pathology is when you see under the biopsy microscopes, you would notice that the inflammation of the artery often spills over to adjacent structures, right? But it never extends to or never goes on to involve venules. If venules are involved, we should probably suspect microscopic polyangiitis, which is primarily a small vessel vasculitis with a little bit of tendency to cause medium vessel vasculitis, right? So if venules are also part of the inflammatory process, we should be suspecting microscopic polyangiitis. Okay, so far we know this much about the biopsy or the pathology findings. What additional we know is in case of hepatitis B infection, that there may be immune complex deposition. The surface antigen HBsAg complex to immunoglobulins may be deposited in the vasculitic vessels, and we can probably immunostain that to demonstrate such an event from happening. Beyond this, again, how exactly the HBV infection is causing the polyarteritis nodosa is not well known. Right? The final consequence of all this, inflammatory changes or immune complex deposition, or whatever is the pathology that is happening. What is the final consequence? Final consequence is arteries develop aneurysms, aneurysmal dilatation and occlusion. These are the final consequences, right? And when I talk about aneurysms, you should note that it is primarily causing microaneurysms, right? It is causing microaneurysms. Okay, and these aneurysms are usually less than 1 centimeter in size. The affected vessel aneurysms are usually less than 1 centimeter in size. With this understanding of pathology, we will go on and discuss the clinical features. But before we go to the clinical features, let us also understand which vessels are more commonly affected, because clinical features are going to be dependent on that, right? So the most commonly involved artery is renal artery. That is the most commonly involved artery. Apart from that, yes, the arteries supplying the gut can be involved, right? And there can be vasculitic neuropathy, right? These are clinical correlations that we know. But yeah, most commonly affected artery is renal artery, and the artery that is usually spared, which is a frequently asked MCQ. This was asked in the previous INI SS, right? Artery that is spared. Pulmonary artery is usually not involved. It is literally spared. On the other hand, rare cases there may be involvement of bronchial artery, can be rarely involved. But pulmonary artery is invariably spared, which is characteristic, right? Because we have other vasculitic syndromes where there may be involvement of pulmonary artery, for example, Takayasu arteritis, right? Okay. Now coming to clinical features, now we already know that kidneys are the most commonly affected organ, but I also tell you that when I say kidneys are the most commonly involved organ, I am specifically talking about renal arteries. I am not talking about glomerular capillary. Glomerular capillaries are not involved, right? So renal arteritis is the characteristic pathological abnormality here without the glomerulonephritis. So what would be the most common presenting feature of this disease? Yes, because there is renal arteritis, patient would present with renovascular hypertension, right? Thus, hypertension is the most common presenting feature. Okay. Then one more thing that is striking about the polyarteritis nodosa is these patients have a tendency to develop severe constitutional symptoms. So when I say constitutional symptoms, I am talking about patients presenting with fever, patients presenting with malaise, myalgia, and also one more striking finding is unintentional weight loss, right? Unintentional weight loss. In fact, this weight loss is part of the classification criteria proposed by ACR. Yes, I agree. We are standing on a very old classification criteria, but yes, it was a component of the classification criteria, right? Weight loss more than 4 kg since the onset of symptom was one of the component of the classification criteria from 1990. Okay, now after the involvement of kidneys and constitutional symptoms, now let us talk about one more strikingly affected organ, that is peripheral nerve, right? Peripheral nerve involvement. So you should note that more than 70 to 80% of the patients have peripheral nerve involvement in patients with polyarteritis nodosa at the time of presentation or during the subsequent follow-up. And the most common presentation of peripheral nerve involvement in these patients is in the form of mononeuritis multiplex, right? Mononeuritis multiplex. And this, I mean, when I say mononeuritis multiplex, most commonly affected arteries are basically radial artery, ulnar artery, and most commonly affected nerves are radial nerve, ulnar nerve, and peroneal nerve, right? So these are the most commonly involved nerve as components of this mononeuritis multiplex, right? Okay, now coming to the involvement of gut, I have already told you, right? The blood supply to the gut can be strikingly involved, and these patients can present with GI bleed, which is one of the commonest presentation. Apart from that, they can present with pain, which is worse on consumption of food, right? The typical story of intestinal angina, right? The pain that becomes worse after eating food. Okay, now there can also be involvement of testicular artery. So patients very often present with testicular pain because of the testicular infarcts, right? So testicular arteritis is known to occur in these patients, which causes infarcts in the testis, and patients can present with testicular pain. So I have seen a lot of MCQs where they do mention about the testicular pain as one of the complaints. So that should be taken as a potential clue for the diagnosis of polyarteritis nodosa on MCQs, right? So if the MCQ says that this particular patient presented with say some mononeuritis multiplex manifestations and he complains of testicular pain for quite some time, well, we have our recipe or cocktail for the diagnosis of polyarteritis nodosa. Okay. Now skin involvement can be in the form of erythema nodosum, purpura, or livedo reticularis. And also remember livedo reticularis, what we can see in a reticular pattern of skin involvement, right? A meshwork like skin involvement. This is also a component of the ACR classification criteria for polyarteritis nodosa. Okay. So far we have studied about the involvement of GIT, testis, skin, kidneys. Right. Now let us discuss about the diagnosis. So now we know the organ that is involved, organs that are commonly affected. So when those clinical features are present, we can strongly think of the diagnosis. But how do we make sure that our diagnosis is right? Right. So for diagnosis, we should know that we have no standard serological test or the marker for confirmation. If you do ESR, you would notice that ESR is usually elevated in most of these patients, and so is CRP. Right? But apart from that, maybe in some patients there should be elevated WBC counts, but beyond that we don't have anything that can be taken as a clue from the laboratory studies. So finally the diagnosis depends on, the most ideal way of diagnosing is doing a tissue biopsy or arterial biopsy so that you can demonstrate the classical vasculitic changes. What are the classical vasculitic changes? Fibrinoid necrosis, right? Fibrinoid necrosis. So this can be considered as the gold standard for the diagnosis, tissue biopsy or the arterial biopsy, but which may not be practically possible in all patients. So as a surrogate evidence, we can also depend on angiogram, mainly to document the presence of microaneurysm, like you can appreciate in this image. Right? I think you can appreciate that there are multiple microaneurysms of the renal vessels, right? This is actually a renal arteriogram image, and you can appreciate these multiple microaneurysms, right? So this angiogram has to be, I repeat my words, this angiogram has to be a conventional dye-based cath lab angiogram, right? This cannot be a CT angiogram or MRI angiogram because we're talking about microaneurysms. These are usually less than 1 centimeter, and they are very often missed on MRI angio or CT angio, right? So if we say biopsy is not possible and we are going for the angiogram, you have to go with conventional dye-based angiogram, right? So the definitive diagnosis is established when you have the right cocktail of clinical features and you do the tissue biopsy to document the characteristic vasculitic changes, or if tissue biopsy is not possible, you're going with an angiogram to document that the affected organ has developed multiple microaneurysms, right? Okay, so that's about diagnosis. Now before we move on to discuss the management of such a disorder, we will have to also spend some time understanding the ACR classification criteria from 1990. Normally you might have noticed whenever I connect to you on the rheumatology topics, I keep telling you that as physician, I have a tendency to follow the classification criteria as my diagnostic criteria because it really makes the job easier to a physician when we apply the classification criteria. Probably it helps us to make the diagnosis, right? But in case of polyarteritis nodosa, I beg to differ. So here I don't notice that these criteria are of great value in terms of diagnosis, right? We have to finally depend on the same strategy that we spoke about, right? Right clinical context and then go for biopsy or angiogram. But anyway, from the exam perspective, we should know something about ACR classification criteria. So let us see what this criteria talks about. weight loss more than 4 kg since the beginning of illness is one of the criteria, right? Apart from that, libido reticularis, testicular pain, myalgias, weakness or limb tenderness, mononeuropathy or polyneuropathy, development of hypertension, elevated BUN or creatinine unrelated to hypertension or the renal obstruction, presence of hepatitis B surface antigen or antibody in the serum, then angiogram demonstrating aneurysms or occlusions of the visceral arteries. And the last one is biopsy of small or medium vessels containing granulocytes, right? So I have told you in the initial stages of the vasculitis, there will be a granulocytic infiltration, right? So these are the components of 1990 ACR classification criteria, right? And when 3 out of these 10 criteria, more than or equal to 3 out of these 10 criteria are satisfied, we classify the case as polyarteritis nodosa, right? So this is a classification criteria, definitely not the diagnostic criteria, and I personally don't find this really very helpful in terms of real world diagnosis, right? We have to eventually depend on biopsy or angiogram itself. Okay, coming to the management of polyarteritis nodosa, right? The simplest way to manage these patients is to give them high dose glucocorticoids. That is the mainstay of treatment for idiopathic polyarteritis nodosa. But when we talk about the secondary, right? So we have to understand, when we talk about management of polyarteritis nodosa, we should know how do we manage a case of idiopathic polyarteritis nodosa, how do we manage a case of secondary polyarteritis nodosa, mainly with attention to the hepatitis B and hepatitis C, and how do we manage the complications. So we know that the most of the complications are related to hypertension or the renal involvement, right? So the general way of managing these patients is to treat them with a high dose of glucocorticoids. Okay, but if it is complex, we might have to, complicated cases, we might have to think of alternatives, right? So let me take you through some important decision making steps. If there is hepatitis B associated polyarteritis nodosa, right? Such situations, we manage them with short course of glucocorticoids, usually oral, usually around 2 weeks, right? That is why I call it as short course. Plus we treat them with antivirals, right? The preferred antiviral generally nowadays is tenofovir, either TAF or TDF, right? TAF or TDF. Or if you don't want to use that, maybe you can also consider entecavir if there are contraindications, right? You can consider entecavir. Plus there is a third thing that we should do is PLEX, right? Plasma exchange. That is the way to treat patients with HBV associated polyarteritis nodosa. Short course of glucocorticoids for around 2 weeks plus antivirals. That is the mainstay of treatment in the form of tenofovir, either TAF or TDF, or entecavir if tenofovir is contraindicated, plus plasma exchange, right? So that ensures recovery in more than 70% of the patients. Okay, now you guys already know that the presence of the extra hepatic manifestations of hepatitis B is indeed an indication for initiation of the antivirals. So you have to start antivirals once you have diagnosed HBV related polyarteritis nodosa. Okay, so that is about the management of HBV. If HCV is responsible, yes, you have to treat them with antivirals, right? Whatever genotype specific regimens you can pick up, you have to pick up and treat them accordingly, right? So if it is primary idiopathic, glucocorticoids. If it is HBV related, antivirals with PLEX and short course of glucocorticoids. If it is HCV related, again treatment with the antivirals. Okay, but now if irrespective of what is causing it, if there is severe multi-organ disease, or if there is vasculitic neuropathy, right? Patients presenting with mononeuritis multiplex, right? Or patients presenting with the organ dysfunction, right? In these cases, in these two circumstances, we generally treat them with a combination of glucocorticoids plus cyclophosphamide, right? So that is the treatment modality, cyclophosphamide plus glucocorticoids. Okay. Now the last point you should note about the management of polyarteritis nodosa is the drug of choice for management of hypertension, right? So we are talking about renal artery involvement. We should be cautious, but still the drug of choice is ACE inhibitors. ACE inhibitors are the drug of choice. If not controlled adequately with the ACE inhibitors, you can add a calcium channel blocker, or you may switch over to a calcium channel blocker. You may switch over to a CCB like amlodipine if patient develops worsening renal functions in the form of decrease in GFR or increase in creatinine by more than 30%, right? Decrease in GFR or also increase in creatinine by more than 30% from the baseline value before you started with the ACE inhibitors. Otherwise, if that doesn't occur, a patient holds on with his renal functions, the drug of choice remains ACE inhibitors, right? Okay, so that is the approach to management of a case of polyarteritis nodosa. Now we will go on to discuss Kawasaki disease, right? For a physician, I think we don't need to really spend too much time behind this disease. If you know some basics of it, that is good enough, right? What is Kawasaki disease? This is also known as mucocutaneous lymph node syndrome, right? Because this is an acute vasculitic febrile illness presenting with the involvement of skin, mucous membrane and lymph nodes, right? That is why it is called as mucocutaneous lymph node syndrome. We already know that this is a disorder which is more common in children. Usually, most of the cases are diagnosed before 5 years, right? Before the age of 5 years, and the peak incidence usually occurs before 2 years of life, right? So it is rarely diagnosed after 5 years, right? Okay, what are the clinical features? It presents as an acute febrile illness characterized by conjunctival congestion, cervical lymph nodes, palmar erythema with desquamation, a very frequently described clinical manifestation in MCQs, palmar erythema with desquamation, right? So we should take this as a potential clue for the diagnosis of Kawasaki disease. And around 25% of the patients develop coronary arteritis in the form of coronary aneurysms, right? So that is the typical clinical presentation of Kawasaki disease. Okay, one more thing I did forget to tell you is the characteristic polymorphous rash that is seen in these patients. I think you can appreciate in the image, right? Polymorphic exanthema or polymorphous rash. And one more very frequently described clinical finding is presence of strawberry tongue, right? Strawberry-like tongue. One important differential we should know about the strawberry tongue is scarlet fever, right? Which can also have acute febrile illness-like presentation. So one should be cautious about that, or we should treat that as one of the important differential diagnosis. Okay. Now coming to the diagnosis of the disease, we diagnose it based on the clinical criteria. A patient has fever persisting for more than or equal to 5 days, and 4 out of the 5 remaining symptoms are present. Bilateral conjunctival congestion, changes in the lips or oral cavity, polymorphous exanthematous rash, that is what we were talking here, right? And changes of the peripheral extremities, and acute non-purulent cervical lymphadenopathy, right? So 4 out of these 5 should be present, and the fever should be persisting for more than or equal to 5 days. So you can't diagnose this entity before 5 days of the onset of fever, right? Okay, that's all about the diagnosis. Then very often we might have to subject the patients for coronary angiogram because they are prone to develop the aneurysms, like you can appreciate the aneurysm in this image, right? So coronary angiogram may be required in these patients. Coming to its treatment, the best way to treat patients with Kawasaki disease is mainly to treat them with IV immunoglobulins, right? IV immunoglobulins 400 milligrams per kg per day, usually for 4 continuous days, right? That is the regimen for the immunoglobulins. And very often we add a large dose aspirin. We add aspirin mainly to protect the coronaries, right? So because there are coronary aneurysms, patients are vulnerable for coronary ischemia, and having a coronary ischemia at that young age could be really problematic in the long run. So we might have to treat them with aspirin, right? But the mainstay of treatment is IV immunoglobulins. Okay, so that's all from me, folks, on this topic, polyarteritis nodosa and the Kawasaki disease. We will be connecting again on another video to discuss the microscopic polyangiitis, granulomatous polyangiitis, and also we will be discussing the eosinophilic granulomatous polyangiitis. That's all from me, folks. We will be connecting on next video to discuss one more important topic. Till then, I wish happy learning for all of you. Thank you.